So there are several things that affect a patient's sleep when they're critically ill. The obvious one is the environment. We all like to sleep in a nice, quiet, comfortable environment. And for someone who's critically ill, they're generally not comfortable because they have lines and tubes in them. They often are experiencing pain. It's certainly not quiet. There's a lot of noise, beepers going off, alarms going off, people talking in the hallway, televisions on in the room, etc. And some of the medications that we give them also disrupt their sleep. So it's multifactorial. There are many different issues that adversely affect a patient's sleep once they're critically ill. Yeah, so for somebody who is not critically ill, one night of sleep deprivation can really affect your executive functioning. That's your ability to respond appropriately to questions or commands to do things, your ability to understand your environment and respond to it appropriately. Once somebody is critically ill, that can be quite exemplified. So somebody who is critically ill gets one bad night of sleep or two bad nights of sleep, and they're coming in and out of consciousness because of sedation, might actually get quite delirious. And for the first time in the last couple of years, we've started tying sleep and delirium in patients who are critically ill. And so we do think that a good night's sleep is important in preventing delirium, but we haven't teased it all out yet. So many places have done quite a bit. So we actually have quiet time now in many ICUs where from the hours of 11 p.m. or midnight till 4 or 5 a.m., very few interventions actually happen. The lights are turned down, the place tries to be quiet, etc. The alarms are placed over at the nurse's station rather than alarming in the room. All types of things to simulate a normal sleep environment. The other things that we're trying to do is get nursing and respiratory therapists to bundle interventions so that they only go in the room once or twice in the middle of the night rather than every 10 minutes. Try to think of all the things you have to do in the next 1 to 2 hours and do them all at once rather than going in and out. Medications is a big thing that we've changed dramatically in the last several years. Prior to really sort of understanding the importance of sleep in the ICU, we used medications called benzodiazepines for sedation in critically ill patients. We now know those are associated with delirium, and they also adversely affect some of the deeper stages of sleep. And so we're now not using them as often, and we're using other medications that are much more amenable to a better night's sleep. So for sleep disturbance by itself, we don't know, but we know that sleep disturbance is associated with delirium. And so the existence of delirium in a patient who's critically ill long-term has a worse outcome for them. They're more likely to be institutionalized or maybe not even survive a year. For patients who are on a mechanical ventilation for a longer period of time because of their poor sleep, that might mean a tracheostomy or being on a long-term ventilator. If they had had good sleep, they might not have been in that situation. But we really don't know exactly sleep leads to whatever down the road. We know it's associated with things, but we haven't fully confirmed all of the things that we suspect are happening because of bad sleep.